Again, a very good morning to you, ladies and gentlemen, and welcome to the inaugural scientific sessions of Sri Lanka College of Specialist Family Physicians. And today we have the main congress, and to welcome all of you officially, I have great pleasure in inviting Dr. Niroshini De Silva, consultant family physician, base hospital Maravilla, pardon me.
Good morning, very good morning to all. And today we welcome you on behalf of the Sri Lanka College of Specialist Family Physician. Our theme is today, Primary Care, Resilience in Challenging Economies, Way Forward to Universal Health Coverage. Thank you.
Thank you very much, ma'am. And to commence the day, we have a very interesting session, that is the picture quiz. So before that, I believe that you all have been registered, because for this quiz, if to take part in this quiz, you have to be registered, you have to obtain your registration number. And then after that, we will be showing you a QR code. So do scan the QR code, and then after that, you will be getting into this Slido screen in your phone. And from that, you can enter your name, and you have to mention the registration number. The reason being, if we have two persons with the same surname, we can identify them by the number. So if you all have not obtained a number, please make sure that you go out to the registration and collect your number. And each question, you will be given 60 seconds to answer. And we'll be selecting the fastest fingers as well as the person who is with the most correct answers after this session. And after every question, we have our lecturer who will be taking you through the question, elaborating about the question furthermore. So I now take this opportunity to introduce our lecturer, who is Dr. Kapila Bandutilake. Dr. Kapila Bandutilake is a consultant vitreoretinal surgeon in the National Eye Hospital, Colombo, and is one of the first vitreoretinal surgeons in the country. He is the current president of the College of Ophthalmologists and the Association of Vitreoretinal Specialists of Sri Lanka. Dr. Kapila is also a postgraduate trainer and a member of Board of Study in Ophthalmology. He was a co-investigator in numerous World Health Organization and World Bank-funded projects on prevention of visual impairment due to diabetic retinopathy and application of artificial intelligence in ophthalmology. Dr. Kapila was accoladed in 2022 with the prestigious SAO Excellence Award at the South Asian Ophthalmologist Conference in New Delhi. And ladies and gentlemen, with great pleasure, I invite Dr. Kapila Bandutilake to stage, please.
Thank you. Good morning to all of you. President of the College of Specialist Family Physicians, Dr. Malkanthi Galena, chairpersons, all invited speakers, distinguished guests, trainees, ladies and gentlemen. At the beginning, I want to express my gratitude to the President and the Council for inviting me to this special event. As an ophthalmologist, I understand the critical importance of strengthening primary care in any country, primarily managed by primary care physicians. My conviction in this matter was further solidified by the keynote speech at yesterday's event. Diabetic retinopathy and glaucoma, which are vision-threatening conditions, have evolved into epidemics not only in Sri Lanka but also globally. The most effective approach to combat this disease is prevention, ensuring the well-being of patients, their families, society, and the overall economy of any country. Without further ado, let us delve into today's topic. I have selected a few straightforward cases that we believe should not be overlooked, overtreated, or undertreated. A basic naked eye view or a simple light source or an ophthalmoscope is sufficient for identification of these diseases. A brief medical history is accompanied by a picture to arrive at a likely diagnosis. So going forward to the first question.
So before we commence with the questions, again, I'm reminding you regarding how you have to scan the QR code. Then after that, in the Slido, you have to mention your name and the number that you have received from the registration counter. So after that, we can proceed with the questions. Sir, over to you.
The first one, a 24 years old girl presented with a lump on her right eyelid for more than 1 month. It is relatively painless. What is the diagnosis? There are 5 answers. Good. The answers, most of the people answers more than what I expected. Actually, what you see is a Calician granuloma. The Calicians are very common, and most of these patients will come to the general practitioners and the family physicians saying that lump. So this lump is particularly, you can see that little bit lower from the lid margin. And most of the time these lumps are not painful because these are from the meibomian glands, which are about 20 meibomian glands in each lid, upper and lower, and the orifices get blocked due to infection or inflammatory causes which give rise to this lump. So what's the treatment? What sort of a treatment we offer to these patients? We don't have to, most of the time, if it is like not a painful one, we have to expect that it's not an infective type. In that case, if it is like a first instance, we can just offer them heat fermentation, and that will be most of the time empty the gland. But if it is not like, if it is an established situation, then we have to open it up. It is also a small procedure. I have shown you the procedure. What we are doing is we give a small local injection. Actually, this is done by the medical officers trained. So give a local injection. We use a special type of a forceps where we isolate the gland and we reduce the hemorrhages, and then use a small nick and scoop out what's there. So that is the treatment for this one. And what you saw is the granuloma, Calician, which was infected. Then later on, it has opened up and became a granuloma, which we have to just remove that part and drain it. Question number 2, a 4-year-old nephrotic child on oral prednisolone presented with a history of vascular rash and constitutional symptoms of fever and lethargy. What's the diagnosis? Okay. Percentage of correct answers is as expected. Actually, there are a few points I want to highlight. The thing is that I know that you will be able to identify the herpes zoster ophthalmicus, but 7% has given the answer is like herpes simplex. How do you differentiate this? And what is the importance of identifying herpes zoster ophthalmicus? So that now in this case, the difference between the previous and this one is you can see that here the same vascular type of rash, little bit different like that you can expect. And you can see that rash is not limited to the upper area, but it is, you can see lower lid also in this rash. So if you move forward, you can see that, you know that this herpes zoster, it's a latent type which is started from the ganglia. It can distribute spread along the 3 branches, ophthalmic branch, maxillary branch, and mandibular branch. You can see the distribution of the ophthalmic branch, which will involve the side of the nose. If you go back to the picture, previous. Okay, you can see that the side of the nose also involved in here. So, and which obey the dermatological distribution of the nerve, and other important point is it is involved the side of the nerve. What is the importance of side of the nerve? That means that we know that this is herpes zoster ophthalmicus because it involved it obey the distribution of the dermatome, and at the same time side of the nerve means it is a ophthalmicus branch. So that's because when this type involved in that branch, that means that we have to expect some involvement of the cornea and the sometimes anterior chamber and uveitis, which is very important to identify because the involvement of other branches are not that important because that will settle itself or you have to treat antiviral, that doesn't matter. But in this situation, you may need opinion from the eye surgeon. That's the point I want to highlight here. So we know there are two things. One thing is herpes simplex, which won't obey the dermatomal distribution. At the same time, the Hutchinson sign, that is the involvement of the side of the nose, is very important, because in that case we know that we have to expect the involvement of eye. The question number 3, a 34-year-old individual presented with a history of declining vision for over 6 months. He has observed that his vision is significantly impaired during bright daylight, and he experiences difficulty in night driving. He is being bothered by glare. What is your diagnosis? Most of the doctors I were able to identify. Actually, it's a cataract. But this is called posterior polar cataract, a form of a congenital cataract commonly associated with posterior capsular changes that can be autosomal dominant or sporadic. And so the thing is that I have shown you the photographs. This is not that difficult to identify. But when it comes to your setting, there are a few things. One thing is a young person comes with the decreased vision. Usually we won't expect cataract. Second thing is, when it is not dilated, it is very difficult to identify. But the certain clinical symptoms are very important here, because he complains of blurring of vision, especially night driving and daylight. So what happens here? You know that what happens is, usually this one is a mature cataract. What you see, this is very easy for you to identify. Even if you just a torch, you can see this type of cataract. So, but this particular cataract, if it is not dilated, you feel like there is no cataract. But what you have to do is, you have to use your ophthalmoscopes, and you have to find your red reflex of this patient. So when you see that, you can identify these type of cataracts. The thing is that similarly, this cataract, this is also different from that one. This is usually you see these type of cataracts, patients with, especially young patients with diabetics and who are using steroids. So this is different from that. This is also difficult to identify, because when you see them like undilated, you will not be able to identify. But if you try to elicit the red reflex, with the red reflex, you can nicely see a central opacity. The previous one, what we were talking about, called posterior polar cataract, these cataracts are really dangerous, because these are the posterior capsule. That is the part we are leaving when we do the cataract surgery. These cataracts are involved in the posterior capsule. If the inexperienced eye surgeon try to do these cataracts, most of the time they rupture the posterior capsule and they drop the things into the eye. So it has to be done by a well-experienced person, because they are really difficult cataract. Okay, number 4. The symptoms of this is very important. The 74-year-old male presented with 2 weeks of floaters and flashes with blurred vision, followed by curtain-like vision loss obscuring the inferior portion of his left visual field. What is the diagnosis? Okay, the answer is retinal detachment. Most of you are able to identify it. Actually, the picture, I think that if you can see this type of picture, I don't think it is difficult to identify it. But in your practice, I don't think you will be able to see this type of picture with the ophthalmoscope, unless we use a slit lamp with a viewing system, because most of the time. So yeah, if you see this picture, you can see that retinal detachment, which is coming from up, and you can see this is the retinal tear. So the important point is not this picture, but the point is the history. You can see that he's complaining of floaters and flashes. Why floaters? Usually when retinal tear starts, there's a blood comes into the vitreous cavity, so which the patient will be able to see as a floaters. Why do you have flashes? Because usually these tears are due to traction by the vitreous, which I show you later. Because of these tractions cause the retinal tears. When traction on the retina, it's like this. You can see that this picture, the right side, you can see a retinal tear. When there is a traction on the retina, the only language retina knows is not the pain or anything, but the light. So they see flashes. These are the two important things. Then they complain of curtain-like thing. That is that retina is starting detaching. And he says that it is from down, because detachment is upside. Always inside the eye, the images are inverted. So that is the one. So the common presentation in around 55 to 60, 70 years is a floaters. All these floaters are not retinal detachment. Usually your vitreous, like your left side picture, you can see that vitreous contracts and it comes out from the retina. That can cause the floaters. So these floaters are not retinal detachments, but still we have to exclude any retinal tears associated with this type of vitreous detachment. An 8-year-old boy known as asthmatic presented with a red eye, itching, and severe photophobia. What's the diagnosis? Yeah, most of identified as vernal keratoconjunctivitis. That's correct, because you can see the special like a feature. This is called cobblestone appearance. Most of the time the kids in this age present with the photophobia, itching, and things. If you invert the lid, you can see this particular appearance. This is a vernal keratoconjunctivitis. Means there's, if you examine the cornea also, there are some changes, and this kids need, sometimes we have to treat them systematically, systemic treatment as well. And in addition to that, topical steroids and sometimes mast cell stabilizers will help. At the same time, we have to look into what is the causative agent. Sometimes you find that they are using some sort of like facial talc and powders and some irritant type soap and things. So we have to avoid these things as well. The patient evoked the morning of presentation with a black spot inferior temporal to the fixation. This was accompanied by blurry vision in the left eye. The patient had poorly controlled asthma the day prior to the onset of visual symptoms associated with intense coughing and coughing episode. What's the diagnosis? Good. Okay, this is so this is a valvular retinopathy where you can see that what happened is you know that this usually happens in young people. Those are maybe less than 40 years like. So what happens is because of the valvular maneuvers, there's a rupture of the small blood vessels like somewhere here, and blood collect inside here. You might find how this happened, why there's a layer, you can see a level here. What happens is, this is the space between the retina and the vitreous. The vitreous is attached to the retina. So these young people, there's some sort of a strong attachment. So the blood collect in between these two spaces. Usually, typically these patients present with the acute painless loss of vision, usually followed by a coughing and maybe some other things like valsalomine, like vomiting, weightlifting, blowing muscles, maybe even some sort of a compressive injuries. There's like a recently, not like about some time back, within 1 year I saw about 2 or 3 young ladies presented to me with this one type of cases. These are all were following the cosmetic facial. They have gone for a facial, and while they are doing this facial, somebody has to hold in their lid tightly, and suddenly they have decompressed. That means they removed the hand, and because of that they got this type of hemorrhages. So sometimes we have to go for surgery, because when the blood is, it is out from the vessels, it is very toxic to the retina. So we have to go for surgery. In your sit-ins, I don't think that you will be able to identify these type of cases promptly with ophthalmoscope. Still, if you suspect, there's 2 options. One thing is you can send to eye surgeon. If it is difficult or not available, you can ask for a fundus photograph. These things are available, easily available nowadays, and you can identify and you can send the patient immediately to somebody. A 68-year-old individual diagnosed with diabetes and hypertension for over 15 years presented with a sudden onset of double vision. The symptoms is particularly pronounced when he gazes into the distance. What is the diagnosis? You can see the different gaze positions. Okay, it is a 6th nerve palsy. So go back to the picture. So if you can see that the different gaze positions, you can see that the eye moves with all these positions except this one. This one you can see that right eye moves while left eye stays centered. So you know that there's some problem with this side, the left gaze. So it is the left 6th nerve palsy. So these are very common things. These are common presentation to in your setup, because most of the time these patients present with sudden onset of double vision. So we don't have to worry about this that much if they are old age with the hypertension, diabetes, because we can consider it as a mononeuropathy. So, but these certain symptoms are important. Now, if it is a 3rd nerve palsy, it is very easy. They will come and tell you that ptosis with near vision issues, because they can't move eye towards the center. When it comes to the 4th nerve palsy, their complaint is they can't go down the steps, because you know that it is oblique muscle. When it comes to the sixth nerve also, they tell us that they have a double vision. They look at the distance because I should go out and should get in a parallel position, which is they are unable to maintain. So it is very easy to identify these cases with mononeuropathy, these cases with this type of mononeuropathies, but still you have to exclude multiple nerve palsies, headache, and the disc edema with the ophthalmoscope, because if there is a disc edema, then we have to, they need a quick referral to the neurological assessment. So what we do is in this, if you are not sure about our diagnosis, we are doing a test called Hess chart. This is the Hess chart. Simply, we can get it done through the through the optician. You can see that this is the affected eye. You know that this is affected eye, the cage, the black color cage smaller than the other eye. So what happened is this eye can't move to that direction, while the other eye, this is actually the right sixth nerve palsy. So here you can see that the left eye tried to move that way. That's why you can see that that's called overaction of that left side. Okay. This is a 35 years old obese lady presented with a history of headache and transient visual obscuration. So blood pressure is normal. What's the diagnosis? History of headache, transient visual obscurations. Good. The last answer. It is benign intracranial hypertension. So here are the two symptoms, what I was talking about. One thing is the 35-year-old obese lady, then headache and transient visual obscurations. I didn't tell you that there's a vision reduction, but there's a fluctuation of vision. When you see a person like this, well, you can actually, with the ophthalmoscope, you can see a bilateral disc edema. If it is a bilateral, we have to consider it as a papilledema. The other most important thing in this stage, what is that we have to exclude, is, we'll go move, is this. Now, this is actually, this one, you can see that this is also disc edema. This is a young lady, they presented with a history of, here the presentation is different, they comes with a decreased vision. So when you examine, you can see a disc edema, and usually it is unilateral. So what is that? This is, so difference is, this is, we have to consider it as a, optic neuritis. While the previous one, there's the vision is almost there's no that problem with the vision. So difference is that here, because optic neuritis is directly optic nerve is involved, because of that vision is low. So they have a relatively young presentation, is decreased vision, they have relative afferent pupillary defect, and they require prompt diagnosis and further evaluation, while the previous lady also need to exclude any neurological, she require neurological assessment as well. But here we have to identify this as optic neuritis. So optic neuritis is unilateral with a decrease of vision. 68-year-old diabetic patient present with a history with a red eye, irritation and eye pain with decreased vision. What's your diagnosis? Good. It is a corneal ulcer. So here there are one thing is a red eye. You can see that definitely inflamed eye. There's a opacity, whitish color opacity over here. And you can see this line. This is hyphema, the pus inside the eye. So this is a corneal ulcer, which need a quick intervention. You have to refer him immediately to the eye unit. Otherwise, what will happen is these ulcers are very difficult to treat, and they can penetrate into the eye, and there will be a perforation, and we have to go for a corneal graft. So now you can see that sometimes they present with a red eye and a similar picture, but if you see carefully, you can see some sort of like a shadow there, not like a whitish opacity. So these type of things are very common with the patients with the diabetes and sometimes some neuropathy and things. You can see this type of. So here, if you stain, you can see ulcer. This is a typical viral ulcer, which sometimes we are tend to miss. These viral ulcers, we have to stain with the fluorescing only. We will be able to identify them. So these are two types of ulcers that separately we have to, the treatment is also different. A 56-year-old female presented with sudden onset of loss of vision in her right eye. She has a past medical history of hypertension, hyperlipidemia, and diabetes. What's your diagnosis? Good. Okay. it's a branch retinal vein occlusion. How to identify? I have to differentiate from branch artery occlusion. Usually there's a spillage of blood you can see over there. This is a superior branch vein occlusion, where is a block somewhere close to the disc, only the superior branch. When there's a block, what will happen is there's a outflow, pressure goes up and blood spill. So you can nicely see the occlusion there. So these type of cases present with a decreased vision, and you will be able to, sometimes you can easily assess them with ophthalmoscope. Otherwise you can take a photograph, and fundus photograph will show you. The thing is that the difference between now, so you can see that this case, the right side, you can see the hemorrhages are all over the retina. So it is not a branch retinal vein, but branch central retinal vein occlusion. Now, how to differentiate from diabetic is, you can see that diabetic also, you can see hemorrhages, but you can see hard exudates here, and these are like some changes of the blood vessels and things. Here, the right side also, you can get a hard exudate and other changes, not the acute stage, but late stage. So if you do a scan of these patients, retinal scan, just I want to show you a retinal scan, you can see that retinal swelling is there. That's the reason for acute reduction of vision. So these type of patients, if it is like this patient has all the risk factors, so we just have to check for the further investigated for the risk factors. But if it is like a young patient, maybe less than 40, 30, then we are really worried, because these people, sometimes these right for retinal vein occlusion without other risk factors, then we have to investigate them extensively. Because most of the time, sometimes it can be antiphospholipid syndrome or homocystinuria or some other coagulopathies. Okay, we are ending up there. Thank you.
Thank you very much, sir, for that interesting session, the picture quiz. That was, ladies and gentlemen, Dr. Kapila Bandutilake. And we will be announcing the winner and the fastest fingers, as you could see on screen. And the winner will walk away with a gift, courtesy of the Sri Lanka College of Specialist Family Physicians. And to give away the gift, I believe the winner anonymously, you can see Dr. Madhu, number 50, has scored 10 out of 10, and also she's the fastest to answer all the questions. Sir, I believe by inviting you to give away this gift to the winner, Dr. Madhu. Congratulations, Dr. Madhu. And in appreciation of conducting an amazing picture quiz, to give you the token of appreciation to our conductor, Dr. Kapila Bandutilake, sir, please remain on stage, because there's a token of appreciation to you as well. And I cordially invite the past president of the college, Dr. Lanka.